Welcome to today's interactive webinar from the Carer Knowledge Exchange, focusing on empowering carers when systems are complex. My name's Alex Lee and I am the chair for today's webinar. I have a lived and living experience of being a carer for a loved one who experiences complex mental health challenges. And I'm also a Carer Advisory Group member for the Carer Knowledge Exchange, and I look forward to facilitating today's session. I would like to start by acknowledging the traditional custodians of the lands that we are all meeting on today. For me, that is the land of the Gadigal people. I also wish to pay my respects to the elders, past, present, and emerging, and to all First Nations carers and communities, especially anyone who's joining us today. Please do note that today's session will be recorded and shared for on-demand viewing. Just to give you a bit of background about our previous webinars, the last two Carer Knowledge Exchange webinars focused on understanding carer recognition and empowerment. And we considered some of the challenges and limitations of those terms and exploring what it looks like to empower carers in the service setting. You can view the recordings of these webinars on the Carer Knowledge Exchange digital platform, and the link will be posted in the chat. With this third and final interactive webinar on the topic of carer recognition and empowerment, we want to build on the rich discussions that we have had so far to find concrete ways to inform policy. Now, there are a number of significant policy and reviews and reforms happening at the moment across aged care, disability, carer support, and other service systems that carers do access. This is a great time to bring the evidence base and the carer voice to policymakers. What has really come through the last two webinars from the researchers, policymakers, practitioners, and carers who participated is that service systems are complex and increasingly so, and the onus is increasingly being put on carers to work out how to navigate this complexity. We see a lot of emphasis on how carers can inform and upskill themselves to better navigate systems like the NDIS, My Aged Care, Centrelink, and healthcare. And yet the time, energy, and resources that it takes to understand and access these ever-changing and often inefficient systems can add a huge amount of stress to carers who are already facing challenging roles. What we would like to do in this webinar is put the onus back on the service systems to become less complex, to reduce the pressure on carers. Rather than expecting carers to absorb this complexity, we want to look at what the evidence base and what carer experience tells us are the opportunities for positive change within service systems. During a discussion panel comprised of researchers and carers, we will start by looking at the importance of integrated, carer-inclusive service systems. We're going to have a workshop-style breakout room to engage all the participants, every one of us, in identifying opportunities to make service systems less complex for carers. And today's webinar is going to run for 2 hours, including a short break before we go into the breakout rooms. Now, it is a great pleasure to introduce our panelists for today. Today, we're going to hear from, firstly, Dr. Ruth Brookman, Research Fellow from the Marks Institute for Brain, Behaviour and Development from the Western Sydney University. Second, we have Dr. Karen Hutchinson, who is a Carer Knowledge Exchange Research Advisory Group member and a Research Fellow with the Australian Institute of Health Innovation from Macquarie University.
Apologies, everyone. We've just lost Alex's audio. Our third panellist today is Professor Keith Hill, Director of the Rehabilitation, Ageing and Independent Living Research Centre at Monash University. We also have two carers on our panel today, in addition to Alex, our facilitator. And that is Timothy McKillop, who lives in regional New South Wales and cares for his son living with disability, and Najla Turk, who is a carer from a multicultural background and cares for her husband, who lives with younger onset dementia, and also recently cared for her aging father. And I can see that Alex has joined us again. Can you hear us okay, Alex?
I am hearing you loud and clear. I'm very sorry about that. I don't know why my Zoom frozen. It's my computer's fault. So we have, thank you, Sarah, for introducing everybody, and we'll go into some questions for all our panelists today now. So I'll start with Tim, and then I'll go to Najla, if that's okay. Now, first of all, Tim, you care full-time for your son who lives with disability. Are you able to tell us a bit about what is involved in your caring role on a day-to-day basis?
Certainly. Hi, I'm Tim. I'm on Ngunnawal and Ngambri land at the moment. So I have a 7-year-old autistic son with ADHD, also has a brain malformation called Chiari malformation. Day to day is a lot of supporting him with daily tasks, both physical and environmental. He has some struggles with fine motor skills and all of that. Getting him to school, he's in a supported learning unit at a public school. Then a lot of dealing with invoices and the NDIS through his therapies, as we're self-managed. We work on a key worker model, so I will do a lot of the therapies and then provide that support with him directly with me and him where he's much more comfortable. We have quite a bit of dealing with advocating for him, especially through the education system, where we average probably 2 to 3 phone calls a week from the school, and having to support him through that as well. Then obviously providing the actual therapies when he's at home. A lot of this changes day to day. It all depends on our family and his own capacity. So it's always a really fluid thing, and having to know when and where to be able to put that support in place. It's pretty much it in a nutshell.
Yeah, thank you so much, Tim, for sharing. And I'm definitely hearing you that it is a changing day-by-day proposition. I'm sure a lot of our carers would resonate with that. Now I'll move on to Najla. You are currently caring for a husband who has younger onset dementia, and you also recently cared for your father. Would you mind sharing what a typical day currently involves for you as a carer?
Yes, thank you very much. Look, first and foremost, I'd just like to say that culturally, we're not about putting our elderly or our sick ones in a facility or aged care. So we sort of do 24/7 home care. Yes, I'm currently caring for my father passed, but I'm caring for my husband. And I do have NDIS, so thankfully I'm blessed to have NDIS. However, my husband is 24/7 care. So I'm working 3 shifts around the clock, and I do have support workers that come in, which I don't know whether it's a hindrance or a blessing, because there's so much extra work that's involved. But our day, look, it's all about, for me, it's cultural obligation that is really very stressful. Lack of support, the stigma that we have in the community about dementia and disability for that matter. And so I feel like I'm on my own. And when I say on my own is during the evening when he's not sleeping, when he wanders during the night, and he might go to bed at 1, 2 a.m. in the morning, I have to be there for him because he can wander out. Or if he doesn't wander out, then he gets very aggressive. So I'm dealing with anger management issues in the middle of the night, and I've got neighbours coming in the next morning saying, "Are you okay? Are you safe?" All the rest of it. And then my day starts at maybe, if I'm lucky, 7 a.m. in the morning, sometimes earlier. And it's a 2-hour routine to do the personal care for him. So personal care, if I'm lucky, I don't have to do a cleanup. He goes straight into the shower. If not, then there's a cleanup. And there's just it's physical, it's mental, it's emotional. So it's 2-hour morning personal care. And then the support worker comes in, takes him out for a few hours. And then I'm on NDIS. Contacting service providers, I'm not managing, self-manage. I have a plan manager that manages, but there's all that liaising with a support coordinator, then with the plan manager, with the service providers, and with the support workers. So I feel like I'm a full-time employee, on behalf of NDIS in managing all his services. So he goes out for a few hours. I go then manage the home. I'm one-man band. I have a house which is, you know, falling apart. And then when he does come home, then it's engagement, it's all the triggers, anything is a trigger for him. You know, touching him could be a trigger, speaking to him. So my husband's situation at the moment is he's non-verbal, whereas 12 months ago he was verbal. Mobility is a lot slower now, so it's like having a toddler. We've got bowel movement issues, we've got continence issues, we've got a whole heap of swallowing. And so everything needs to be documented, and GIS is all about documentation. So it's constantly recording and then following up with the support worker and who recorded what, how much fluid did he take in, what was his diet like. So, you know, I'm the nurse, I'm the wife, I'm the sister, I'm the carer, I'm all of the above. So yeah, that's in a nutshell. I just feel like, you know, no 2 days are the same. And I don't see a start and end to my day. They just carry through. And I feel that because of the situation, the complexity of being not just a carer, but being a cultural carer, because family and friends, as much as, you know, we know they're there to support you, when there's cultural stigma, they're unwilling to support, they're unwilling to be present. And so, yeah, it's just, it's a huge, huge responsibility.
Yeah, thank you so much for sharing, Nigel, and absolutely hearing you about both the cultural and the mental health the health stigma as well, and also the multitasking, and that really goes to show what the importance of dealing with the complexity of the system, which really brings us to hearing from our from our academic expert panelists from today. I'm going to start with Karen, and then to Ruth, and then to Keith. I'm going to start with Karen. So what's your area of expertise, and what are you currently working on?
Thank you, Alex, and thank you, Tim and Najla, for sharing your expertise with us in being carers, because what you're saying is so valuable for us all to hear and understand better the complexity. So I just wanted to sort of say thank you for sharing that with us. So I sort of started off as a physio, and I'm still a physiotherapist. And then I sort of wanted to try and make a difference in the way services were delivered. And so I took on a PhD, which wasn't a planned thing, but anyway, I took on that challenge. And I'm now a healthcare researcher as well as a physiotherapist. I've also been a carer for a short period of time as well for my mum, who passed away from cancer, but I had to fly to Scotland to be able to care for her. So I have had some caring experience. And my research interest focuses on enhancing the care experiences through us all understanding better how your care and support needs, and working together to design and look at ways of implementing and evaluating and connecting care together to sort of, so that's person and family focused, and specific to individual needs and family needs. Living with a chronic and complex conditions are basically where I'm sort of focused, because I've spent many years working with people with neurological conditions, which really highlighted the many challenges that people faced accessing and navigating care. And I've sort of been very privileged in my clinical and my research work to listen to many stories and hear from people living and in the caring space, and also sort of living with the challenges of chronic and complex conditions. And I am currently at the moment evaluating a service called Rural Kids GPS, which is a model of care coordination for children living with medical complexity and their families living in rural New South Wales. And also I'm evaluating a multidisciplinary motor neuron disease clinic on the Central Coast, which is trying to support equitable care, as we know that NDIS and My Age Care have provide inequitable care and support. So it's to try and make sure that everybody has equal access to the right care at the right time.
Fantastic. Thank you so much, Karen. And the complexity of family needs is such a massive area, and especially your research looking into with rural carers, that's another extra layer of complexity, which I believe many of our audience today will empathize. So now I'll move on to Ruth. So what are you currently working on, and what is your research focus?
Hi, thanks, Alex. I'm a bit like Karen in that I started in allied health. I initially trained as a speech pathologist and then became interested in mental health. So later in life, retrained as a clinical psychologist and found the best way to do that was to get a PhD scholarship. So I ended up doing a combined degree. And I found in that my PhD project brought together, I guess, the mental health side of things and also communication, which I'm passionate about. So my research focuses on improving well-being within caring relationships, primarily by looking at communication and improving that. So in my PhD, I looked at interactions and improving well-being for mums with postnatal depression and young infants. And in my postdoctoral work, I've been looking at social interactions and maximising those and well-being in relationships with carers and people living with dementia. And we know how important social interaction is to well-being. So, so many of us experience both within the systems as carers, but also the complexity of trying to communicate with the person that's a recipient of care as well. So the main project I'm involved with is under a linkage grant with Dr. Celia Harris, and we're actually looking at improving conversations within residential care between professional carers and residents, and also between carers who go out in the community and provide care, and looking at ways in those incidental interactions of upskilling professional carers to be able to have really meaningful conversations with end users that involves reminiscence and involves helping to connect them to autobiographical memory and to be part of that stimulation in the environment, I guess. And so we're hoping to evaluate a program in which we're training staff to communicate better with service users.
Lovely. Thank you so much, Ruth. Definitely communication is massively important, and also recovery and caring being a relational thing as well. So absolutely hearing you there. Last but not least, I will move on to Keith. If you could tell us about your role and what the focus of your research.
Thanks, Alex. My role has been, until a week ago, being the director of the Rehabilitation, Ageing and Independent Living Research Centre at Monash University. It's a centre that's 5 years old. I've just stepped down as director, and I'm now taking on the stream lead for the ageing well area of the centre, and ageing has been my key focus of research over many years. One of the key things about this research centre is it does bring together what's effectively what could be 3 independent centres. So it's got a focus on ageing, it's got a focus on rehabilitation, and it's got a focus on independent living or disability. And while we see that there's a lot of work to be done in each of those, what they tend to do is operate in silos, and what we're trying to do is bring those 3 areas together and look at intersections between ageing, rehabilitation and independent living, and there are many of those. My own background is as a physiotherapist, and my research since 1998, when I did my PhD, is focused pretty much largely on the ageing well side of things, and has had particular interest in areas of exercise for older people, and also preventing falls for older people, which is a major issue and does contribute to a degree to carer stress. The research that I've been doing also crosses the community setting, hospital settings and residential care settings, and the intersections between those settings, because often there are gaps when older people are tending to move in between hospital and home, or home and hospital and residential care, which can contribute to a whole range of stresses, both for the person themselves who's being moved between those settings, but also the carers. And so, yeah, that's pretty much a summation of my work. We'll touch a bit later on my current focus, but it really is around, my focus personally is on older carers of older people, which is a subset of carers across the board. But what we see is a very important group that are tending to be neglected in a number of the different areas that are being addressed, both in terms of service delivery, but also research.
Thank you so much, Keith. Definitely hearing you there with the challenges facing older people and their carers, and what you said about moving between services and home and the stress that puts on carers definitely can resonate there. So now I would like to come back to the carers, and I would like to specifically focus on some of the challenges that you face. I'm going to ask Najla first, and then I'll go on to Tim. Firstly, Najla, you deal a lot currently with the National Disability Insurance Scheme, or the NDIS, but you also have to navigate aged care and healthcare services with regards to your father. What do you see as the most time-consuming and frustrating things about accessing these service systems?
Do you have an hour? To be honest with you, there were a lot of frustrating things. One, first and foremost, I thought there were much of the muchness, that the service provision would be the same, but so be NDIS is one thing and aged care is another. So it's, you know, you only learn through the pitfalls, you fall through the cracks. But I feel what's common to both NDIS and aging was the amount of time it takes to access services. And you're all well and good, here's the number, give them a call, but who returns your call? How many times must you call them? There's misinformation, lack of information. You're kept in the dark. Now, I speak English and I'm quite competent in the language skills. What chance does somebody from a culturally diverse background have when they're getting somebody on their behalf to call? Now, my personal experience was that last year, my husband's health was deteriorating and we wanted to go in for an early review. So when we called NDIS, they said, yes, it's simple, expend your funds, use up your funds, whatever's there, and then put in a request for urgent review. So we did that. We spent the funding, put in a request. They said, you know, reasonable time frame between 4 to 7 days. So we waited the 4 to 7 days, and 7 turned into 17, then 27, then 37, then 47, then 57, and 67 to 74 days later. 26 touch points, myself and my support coordinator, constantly calling, ringing. Oh, we're the only call center. We're just the call center. Can't help you. This is what it's telling us. So misinformation, kept in the dark. So-called 7 days, maximum 7 days. Now, service providers won't provide services, they're not being paid. I'm pulling in the 24/7 hours in addition to what I'm required to do. And then the fundings get, you know, quarantined. Like there's no funds. And staff, you know, as much as, you know, I respect what they do. And I always say, you know, if you're not doing it from the heart, then it shows. But the staff aren't trained. And so I'm required to train them in addition to, you know, making all the calls and following up. And then, you know, got to a point where I went through all the checkpoints, you know, every single person I can call, you know, and pull in all my resources and expended so many hours, and the frustration only, you know, the last point was like, I'm going to go to the MP. I've got to do something. Like it's got to go to that level. Like I've expended 74 days of my time and energy. And thankfully it came through. So the funding did come through. I thought they were going to wipe the funding altogether. So that was a blessing. Same thing happened with my father. When I asked, required an OT, and they said, yes, you need to wait a few weeks. 2 weeks turned into a month, turned into 2 months, turned into 3 months. And the 4 months later, we thought, you know what, this is not going to happen. This service provider, one service provider for all his services, whereas NDS, you have choices between multiple service providers. So we couldn't do that for my father. So we went to the next provider and they said 2 weeks waiting. And I thought, you know, 2 weeks is a long time to wait, but I will wait. But what happened with my father was they also quarantined his money. And we waited not 1 day, 2 days, 3 days, 10, 20, 50. We waited on average 101 days. So he couldn't get services either. And again, all the telephone calls, call this number, not this number, went on ACAT, they can't, he's not a priority. He was level 3 when he went to hospital, he had a fall, went to hospital, he wasn't doing too well. And, you know, all the complications and the complexity of his heart, his kidneys and his lungs and everything else at the age of 91, he was sent home palliative. And the support, the social worker said, yes, he's getting, we're, upgrading to level 4. So he'll have extra hours and more support. I'm a primary care and secondary carer. My sister's a primary and a secondary. We're doing the best we can. Nothing. We waited not 1 month, 2 months, 3 months, not 4, not 5, not 6, not 8 months, not 9 months, not 10 months. We waited close to 12 months. And the week before he died, ACAT were coming out to see him. A year. And this is somebody that needed quality support. We needed intervention. So the frustration is that we're giving the care, but how the service provider is supporting us? Don't they understand that we're burnt out, we're maxed out, we're using all our resources. So for my father, we were lucky because he's got grandchildren, so we pulled in grandchildren, you know, his sister-in-laws, brother-in-laws, aunties, uncles. We used anyone and everyone to come in to pull, because home care as well. You know, culturally, we don't put them in, you know, facility, residential. And he was, you know, got to a point where he's very, very frail. But, you know, it's all about keeping his dignity and quality of life. And I don't feel that aged care gave us that. And he's paid his taxes. He worked over 60 years in Australia and did everything he could. And the time that we needed them, they failed us. Because, yes, the palliative team came out, but even the communication, like it was clearly, it was the one, as though we were on the one way, you know, the one lane. And it was inevitable where the lane was taking us, but we just needed the support that we needed at the time, and we didn't get it. So I have a little bit of angst there, and hence why I'm very passionate. And I'm here today to share my journey and advocate for every person who's caring for their loved ones, especially the disability and the aging, because they're our most vulnerable, and they've given to society, and they've given to the country. And not to be able to, you know, be recognised as a human being that's worthy of attention, and even responding to calls and even giving us answers. And at 12 months, you know, I thought 74 days was very long. I thought it was a long wait. And 12 months was much longer, and it wasn't a positive outcome for us at all.
Absolutely hearing you there, Angela, and thank you so much for sharing. And I'm very sorry to hear about your experiences. It's what you said about the delays and servers cross-talking to each other. It has a genuine and real adverse impact on people's health. So thank you for your passion and your sharing. Now, if you don't mind, I would like to move on to Tim now to actually ask him that. Tim, you are also very well acquainted with the NDIS, but like a lot of other carers out there, you've also had to navigate Centrelink and health system in general. So what would you like to see changed about these service systems to make life easier for you as a carer?
The short answer, everything. So my bit about my story. I was a tradesman. I was a full-time tradie and struggling with a bit of mental health. So I decided to take over the full-time care of my child while my wife went back into full-time work for the first time in 5 years. A lot of the things that I've found that I feel really needs to change is the biggest thing is communication. Having, whether that's a central information hub or just a bit more communication even within the same system, especially within Centrelink. We also had the wrong information given as we were changing from my wife being on the carer's pension to myself. We were repeating our story again and again. Every time we spoke to somebody, and when we were in the midst of that, I added it up. within 2 weeks, I spent over 30 hours on the phone. So technically in 1 week, I went over my allowable hours of not caring for my son. Yeah, so it's also when support was there, and jumping again into the health system. My son had brain surgery in 2022. We did get given a support person up at the hospital. We were given a social worker. But when we got to that hospital, which is a 3.5-hour drive away, we had to explain our story to them again. We had to explain everything that was there, and we had to do it in a very deficit-based way. And this is what we found with a lot of systems that we're dealing with, Centrelink Health, all of that. We have to speak about our worst possible day. When we're constantly doing that as carers, that bleeds into our caring role. When we're explaining to strangers about our son's worst day, when we're trying to get support for ourselves as carers, we're having to explain about our worst day, almost begging for help. Then when we're actually in our everyday life, it does bleed in. You do sometimes look at that person you're supporting as a burden rather than that's the person you're caring for or a loved family member. Also within that is understanding holistic approaches thrown around a lot. And when we bring up issues that us as carers are having or family members are having, that's thrown down as it doesn't involve the person you're caring for, the person with a disability. That doesn't necessarily matter. So that is, again, another thing that I've found that I'd love to change is the real understanding of what holistic approach, that caring for a carer or caring for a family member bleeds into caring for that person with a disability. And again, within that as well, my last point is for these systems and people employed by these systems to understand that a carer's role is different from a typical parent or family member. They throw a lot of parental responsibility in my situation out, but actually understanding that when you're a carer, that is different from just being a parent or a family member. There is extra things needed. You need to have extra capacity, and you need to find support outside of there to also support yourself within that role as well. That's pretty much what I have. Again, I could probably go for hours as well, but that's as much as what I was able to put into a small amount of time. Thank you.
Thank you. Thanks very much, Tim. And what you and Nigel both said about we can spend a couple of hours on this. I'm sure that a lot of the carers listening into us will be nodding in furious agreement. Now, I would like to throw some questions over to our researchers. I would like to start with Karen and then Ruth and then Keith. Now, Karen, what has your research found about being the main complexities that carers struggle with when they access a complex service system like the NDIS? And now, how do you think your research can help us solve some of those issues?
Thank you. Well, I think Najla and Tim have just highlighted many points that I was sort of going to highlight, and I think that's really important that has come through in their stories that they've been sharing with us. And I just want to highlight that things that have been pointed out have been that fragmentation and lack of connection across the different systems. And sort of some of the other challenges about cross borders. So if you are living close to ACT or if you're living close to Queensland, there is additional challenges navigating those. Information sharing and communication is particularly challenging, and that's already been highlighted. For example, health medical records do not link with other health districts. They certainly don't link with GPs, NDIS, my age care providers and the users. So we've got a real disconnect across there, which then has highlighted the amount of times you have to be on the phone or contacting different people, different providers. And there is particular challenges for people who require support and care from multiple providers. And because as you've both highlighted, it's that sharing of the information all the time, the same stories, the concerns that you might have forgotten something that was really important because you're telling the story over and over again. And I know carers are worried about, oh, what have I forgotten to say something? That might be that important bit. Because you're in a time of stress, you're tired, you're exhausted, there's lots going on. And, you know, and particularly like with the NDIS, it's not consistent. The information that you get is not consistent across the board. And knowing how to communicate with the NDIS. I mean, I've had to train some of my people that I've been working with as a physio on what language to use to ensure they don't say the word pain because it's caused an alarm bell. So we've had to sort of work on how do they describe their situation that the NDIS will understand. It's a complex system to navigate and it is hard to understand. And even like care providers, healthcare professionals, yeah, I speak to a lot of people that don't work with the NDIS. They have no idea how to even navigate. I've supported people who have been in their applications for NDIS. I've had many patients that have been told they're not disabled enough. I've had people saying that they're too complex for the NDIS, living with a life-limiting illness. So, you know, there's real complexity there in how to navigate this. And as both have highlighted, this is a full-time job. This is a repeated, a common thread through lots of discussions, and it's on top of their care responsibilities. But I also want to just highlight the young carers. There are some young carers that are navigating this system for their parents. All of these systems that don't have, that have, you know, maybe not benefit of the maturity of older people, and also are often treated not as well because they are young. They're not listened to, they're not included. So I just want to highlight from a young carer perspective, we need to sort of really, you know, understand that that additional complexity. So from the research, the importance of providing seamless and connected healthcare, despite the many different areas and how it is that needs to be accessed. It needs to be individual and family focused. And we are looking at designing models of care together. So we need to listen to what people are saying. What do people need? We need, it's not researchers designing models of care. It's actually as all of us together looking at models of care. And they should be equitable in the access to all care and support. So care coordination has been shown to be a great way in helping people navigate health systems and disability aged care systems, and helping to improve the access to care. So there's a lot of people get lost to follow-up because it's so hard to actually engage with services. If you haven't got that determination, you maybe don't have that English isn't your first language, or there's just that total complexity. And also care coordination coordinators can help build your capacity to understand, to self-manage and be able to navigate care. So there's that education. In my research, they're often called like the fairy godmother, and that might have been, you know, they're that person. They feel that they are just helping them navigate this complexity. And in our projects, we've actually come across a lot of people from priority and vulnerable populations who are actually accessing care that they never had before. So we've actually increased service use in some areas because people that have been lost in the system or haven't been accessing system have actually been able to engage with them. So thank you very much.
No, thank you, Karen, and I see that there are some agreements coming through in the comments. So now I would actually like to ask Ruth and Keith to offer some of your suggestions and insights about solutions as to the service complexity question, and specifically, how can we reduce the time, energy, and stress that carers spend on dealing with such complicated systems, and so that they've got more time to care and as well as to look after themselves. If I could start with Ruth, that would be great.
Great, thanks, Alex. We actually did a project the last couple of years, which was a collaboration with Carers New South Wales and New South Wales Health, where we actually mapped the journey of carers' experiences over a 6-month period as they engaged with aged care services and health services. And we asked questions like, how could this be improved? And actually asked people to give ratings out of 10 for their experience. And as you can imagine, there was a lot of hit and miss, depending on what area of Sydney you lived in, depending on who your GP was and what relationship you had with the GP and what cultural background you came from. And so if we're thinking about policy generally, and if we're thinking about what we can do as a professional service provider and as a paid carer, the 3 main needs that carers had was for knowledge, that's information, for psychological support, and for social connection. So if we think about how we can facilitate that in every interaction we have with carers and include them in the caregiving journey, what came out was that carers felt that it was the person with dementia who was the patient and not themselves, and how little a professional like a neurologist had to give to make a big difference to that carer, which was a pat on the shoulder and how are you doing, or giving a link to services for carers, was amazing. But it was also amazing how little that happened in interactions and their missed opportunities. So even if we can't change the policy, we can, and we're working towards that, we can change the interactions that we have. And what we found, just to conclude, with it, there are 3 main points of needs for carers in the carers of people with dementia, and that was at the point of diagnosis, the point of needing to navigate systems to get formal support services in the home, and the point of transitioning into residential care. So if we can be aware of those 3 main points of need and the mismatch that often happens, where at that point of need for knowledge, people reported being given a diagnosis of dementia and then being left with nothing, no links to services, no leaflets. This is particularly relevant for those from culturally and linguistically diverse backgrounds, where they weren't given information in their own language, where there was that assumption that everybody goes into residential care. So just put your loved one into care. Informing ourselves as paid carers and in policy of the importance of being culturally sensitive in that way. And what our suggestion would be is to have a dementia advocate or caseworker to travel with carers, family carers, along that carer journey. This is with dementia from the point of diagnosis onwards, to be able to navigate, help them, support them to navigate the complexity in the systems, and also to be monitoring the well-being of carers.
Fantastic summary. Thank you very much for that, Ruth. And now I'll go to Keith for a comment about what your research can do about reducing complexity.
Thanks, Alex. So just briefly touching on a couple of the points from Najla and Tim, there were issues raised around the need for a holistic approach, and that the carers' needs and their own health and well-being tend to be not addressed at all by the system. The system tends to focus, sometimes not very well, as we heard from Najla, with the needs of the person that they're providing care for. So in my mind, a holistic approach, and perhaps where a service that provides for both, is very important, but the system isn't funded for that. We did some research leading into this, and we were told our focus is on the older carers of older people, but we were told that when the carer and the person receiving care goes in to see a specialist, they're told that the focus is on the person receiving care. And so what is not realised is that if the carer's health and well-being is not well managed by themselves and by the system, then the caring relationship is not going to be able to be sustained. So a bit of our research has been recently to look at establishing, it's not necessarily that holistic perspective, but we're setting up a service starting in about 2 weeks at Monash University and Peninsula Health, which is a carer health and wellbeing service. And it's going to be focusing not on the person who's receiving care, but how can the person who's providing the care look after their own health as well as possible. Now, it's recognised that that's not easy. The carer has enormous time demands. You know, I could suggest as a physiotherapist that carers have to be physically active. Well, they're physically active in the home often, doing all the care needs, but they're not necessarily doing the type of physical activity that optimises their own health. There's a whole range of both physical and mental health approaches that could be used. So we're setting up a service that will have a physiotherapist. Well, the focus will be psychologist, social worker, as well as some physiotherapy and occupational therapy time. And it'll be focused on the carer's perceived needs. It's not what we as health professionals think you should have, but it's talking to you about what are your needs and how can we help to manage those. It will be focusing just primarily on the Frankston, Mornington Peninsula area in our location in the first instance. We'll be doing an evaluation of this and hopefully trying to get evidence to support greater funding for this sort of service that puts a very strong focus on the carer, as well as obviously we need to enhance the support and care for the person who's receiving care. That's probably as much as I'll say at the moment given time. Yep.
Thanks very much, Keith. That would be a very worthwhile service. So to close off our panel discussion, I'd like to finally hear from our carers. And first, if I could ask Nashla if you could put in one sentence, I know we haven't got an hour, but if you could put into one sentence, what do you think, what's your reflection from today, especially after hearing from our academic experts on, especially in the context of caring in a culturally diverse community?
I just want to firstly thank Dr. Ruth and Dr. Karen and Professor Keith, because I believe between the three of you, you've nailed all the issues, and it's refreshing to hear that people do understand the complexities, especially from a cultural background. So I just want to thank you, and I'll also say that while I shared my story of being caring for my husband and my father, it's refreshing to hear that we, the carers, are the centre point. So thank you so much for that. I just feel that we get lost in the role because we're caring, and we do tend to forget ourselves, so mentally and emotionally and physically. So thank you so much, and I think that that's the biggest takeaway, that how can we give when we have nothing to give? So we're actually running on empty, and I know I am, because I'm sleep deprived, and just soldiering on. But it comes to a point where I know I have nothing more to give, and sadly, my husband may go on for the next 5, 10, 15 years, and I may not, be here at the end of the year. So thank you so much for allowing us to share and being heard.
Thank you so much for sharing, Nashla, and being here today. Now, how about you, Tim? What are some of your takeaways from today in 1 or 2 sentences? I guess especially in the context of being in rural areas as well.
I suppose my biggest takeaway is we are being heard. As carers, we can see these amazing researchers who have put into words a lot of what I'm hearing from within myself and from other carers that I speak to as well. So it's really heartening to know that what we're saying is not something that's new, that it is being heard and hopefully being put into place to actually provide that bit of extra support for carers, especially Dr. Karen mentioned about the cross-border issue, which is exactly where I'm at. I'm on the border of the ACT. I'm in a regional city in New South Wales. The border's about 100 metres away from where I'm sitting right now. So all of that complexity as well, that I'm sure Karen knows more than a lot. But yeah, I suppose just my biggest takeaway is that there are people out there in a position of power who do know the struggles, and hopefully we can do what we can to actually get some solutions put into place to make it a bit easier.
Amen. And thank you so much for that, Tim. And to all our panelists today, that wraps up our panel discussion for today. But what we're about to do is that I understand there may be some questions coming from our audience. They will be forwarded to our panel discussion members for today. So what we will actually now do is to head for a short break. And what will happen is that the Carers NSW team will be putting everybody into breakout rooms. So that will be the more collaborative, interactive part of today.
I think I'm first came off the rank to report back for breakout room 1. So while that Zoom issue is resolved, shall I get started and kick off the groups reporting back? Alrighty, so breakout room 1, I facilitated. We had a great little group of carers and researchers. We had a really, really robust discussion. And some of the key points that we had, the first really interesting insight was that if we're looking at getting someone that's a paid professional to help carers with the admin side of caring, maybe we could have a link worker or a navigator, which does exist in some situations. But we were talking about how it can't be one person, because not one person can be an expert in all the systems, so it needs to be a team. And then we reflected on, isn't that interesting that it can't be one paid worker and yet carers are trying to do it all on their own? So that was kind of one interesting discussion we had. But the main thing we talked about was how carers differ in how much they want to be involved in the admin and the coordination of care. And so we need to make sure that we're providing all the options and making sure that carers have choice, not just people accessing care services, but that carers have choice. And we sort of tried to work out what are those categories. And some carers that we were speaking to want to be able to do it all themselves. They prefer to have the choice and control over the admin. They are okay to do it. They have the time to do it and the skill to do it. And they don't want to feel patronized like they can't do it, but they also need some additional support and information to help them do that effectively. And they also need to have not such a crowded market of support options that they get confused. And so recognizing that carers might choose to retain that administrative role, but also recognizing that there's a second category of carers that are not in a position to do it themselves at the moment. And they need to be able to, without shame, outsource that to people that are competent, that can do it for them on their behalf and don't create extra work of chasing up or training and those kinds of things. And then thirdly, you've got a group that actually would love to do all the admin, but just in a position now are not able to do it. And maybe if some of the caring load was taken off them, they could work towards that. And so really what it came down to in our breakout room was carers' choice needs to be at the center of this, and carer-led support design, and that there's some promising models in place, but there just needs to be better tailored support for carers wherever they are, in terms of their admin side of their caring role.
Fantastic. Thanks very much, Sarah. Sorry about my Zoom crashing before, and good to be back on track. I believe group 2 is Melissa, group 2?
Yeah, so that's me. So we had a great discussion in our group about how the service systems could be made less complex. We discussed how many service system carers are engaged with, and one carer shared that they're engaged with at the moment with 18 services or service systems. This can be like a full-time job and have significant implications, both practically but also emotionally. We discussed how this ongoing engagement and reliance on carers to navigate these services can result in chronic burnout, and this can actually limit the effectiveness of some of the potential solutions that might even help. But we discussed other opportunities like collaborative approaches of providers with carers, ensuring clear referral pathways and management of expectations, and looking at programs similar to Care Finders, which has special workers to help people navigate or improve access to service. We did highlight, though, in our group that if we look at these service navigation models, it's really important that there is training and ongoing development for those staff, and that they are encouraged and supported to stay in those roles long term, to support partnerships and collaboration and maintain that sector knowledge and expertise. And we also had a little bit of a chat about opportunities for carer peer support in terms of service navigation and the importance of that in building that skills and knowledge. And then we also, in terms of data and collecting that a little bit, information and collecting that a bit more effectively from carers, we did have a bit of a conversation about how assessments and data is used in current service systems, systems, and potentially that might be being used in the wrong way, often focusing on measuring or I guess kind of screening for people who might be using the system incorrectly, however, not always focused on looking at what are the people's needs and actually acting as a barrier to services. And kind of looking at how that data is then used or that information is used. Does it actually result in people following up or making sure that carers are okay or ensuring they're included, or are we just collecting it and leaving it kind of on a system and then it's not really talking to other areas or not actually creating support for carers? And the other element that we discussed just in relation to that information is how carer data is collected and ways that that's been made mandatory, for example, within the health system, and it forces identification and recording of carers so that information is on the system and easily accessible, and the carers don't have to kind of keep, bringing that back to the health professionals and telling them it's already recorded on the system.
Thanks so much, Mel. I think just not having to retell the story is a very big part of it. Group 3, I believe it's Jade.
Hi, it's Alex. We had also some very interesting discussions and crossed over on some of the points raised by groups 1 and 2, actually, but we're focusing a lot on the ways that there needs to be more recognition and engagement with carers across like individual, social, legislative changes. So very much kind of like a whole of government approach, but trying to recognize that carers in navigating these systems do need, for some at least, as you say, some might prefer obviously to be quite engaged in the administrative sort of tasks, but to be able to have that single point of contact, to be able to have someone who can actually support them to be able to navigate these systems, rather than actually requiring that carers have to kind of go through the crucible of learning these systems themselves. We focus quite a lot on the benefits that many carers get out of the sort of the peer support and collective, more informal carer networks, and the ways that this kind of approach tends to mean that you have sort of the social support, but also, the tricks and the ways to be able to access supports, to be able to know these systems in and out. And while that is an extremely useful service for so many people, obviously one of the difficulties that also comes out of that is potentially an area for further improvement is trying to ensure that there's clear communication about how to access those particular groups and to be able to ensure that they're available. And obviously one of the hurdles that we often encounter in this particular space is having sort of support, sort of community peer groups that are going to be a right fit for an individual carer, that are going to be accessible, particularly if we're starting to consider places that are more rural, regional, or remote, or potentially online versus in person. So obviously there's a lot of complexity even just in that one possible solution or one avenue to provide some support or further support for carers. We're also discussing the ways that in this sort of whole government approach, it needs to be a much broader kind of discussion around care recognition and around care identification, and trying to sort of see the ways that the caring role for many, many carers is a non-stop experience. It is 24/7, and recognizing the ways that that caring relationship can have further consequences for a carer in terms of not just day-to-day life, in terms of managing life or their own health needs, for instance, or their own mental health needs, but also in terms of their own individual financial security. So we talked a bit there about superannuation as well, and trying to actually provide some sort of legislative protections for carers to be able to sort of stipulate perhaps, the ways that we would expect to be treating carers, just as we would, for instance, if we're talking about some of the requirements around OHS and paid carers, so paid care workers, obviously. So trying to figure out how we might be able to improve some of these services at all these different sort of minute points really highlighted the complexity, not just of the systems we're talking about, but also of the individual care experiences and the people trying to then navigate those systems. So very wonderful discussion. Again, thank you everyone who was in my group.
Fantastic. Thank you so much, Jade. And group 4, is it Prue doing group 4?
Yes, it is.
Love it. Thank you.
So again, very similar crossovers in group 4 that we've already heard. I think I'm going to keep it quite short. I think some of the standout things from our group was this idea that systems need to communicate better with one another. To break down those silos. And there were suggestions that perhaps the ministry should be looking at how they can generate this ability to communicate, to bring these different systems together. I think another really big thing that stood out in our group was the idea of carer-led support. Carers tend to trust other carers more because of the distrust that has been developed within the system. So how can we make these systems or these support networks more carer-led? There was this idea as well that some systems are actually, or support systems are already working with, which is creating different scripts to provide for carers so that they can get the correct access they need and perhaps not pushed out. Another thing that was discussed was training for the professionals to really understand carers and to listen to carers just as much as they are listening to the person that they are caring for. Another thing that was really highlighted, which I think is really interesting, is actually building in a support system for carers within different systems. So for example, within the NDIS, if there was actually a part of the NDIS that was dedicated to funding things that carers need so that the carers are able to continue their work in a way that is supporting their well-being and their health as well. And then the last little thing was just creating kind of like a centralized system to tap into so that all organizations could view, where there is one, large pile of information that doesn't need to be continually shared. So it takes off that burden of continually sharing the carer's story or the carer's worst day over and over again. It's only shared once. It's trusted that one time, and all organizations have the ability to tap into that piece of information so that burden is taken off of them.
Thanks very much, Prue. That crossovers communication is really coming through. I will now send it off to group 5, which is Ada. Thank you.
Hello. So yeah, we had a wonderful conversation. Thank you to everyone from group 5 who added to that. I'll keep it fairly brief because we also have had quite a bit of overlap in the topics. But I thought something that was really interesting at the start of our conversation was just looking at sort of systemic issues in a lot of our systems more broadly, in particular within healthcare and places like hospitals that are often sort of first point of contact for a lot of carers with services and a place that is really important for carers to be identified, but recognising that often hospitals can be spaces that are not very inclusive for information sharing and especially in regional and remote areas where there's quite a high turnover of staff, especially doctors, and that lack of relationship building is a real hindrance to identifying carers and ensuring that carers are getting the services that they need. And we also spoke on that, just also about self-identification among carers and how that is a big challenge, and that it's really important to create spaces within services where carers are encouraged to self-identify, because without that, we're seeing a lot of carers sort of fall through the cracks. And then going on sort of to talking about assessment processes. Again, we also spoke about the reluctance to use deficit language and carers not wanting to admit the extent of the work that they're doing, especially when the person that they care for is present. So ensuring that in any assessment processes where there's really an opportunity where carers are clearly provided space to share their story and not necessarily with the person receiving care in that space as well. But making sure again that that's in a way that's not re-traumatizing and not requiring people to retell their story. We also found too that a lot of assessments can be quite, we spoke about how they can be quite rushed, quite low quality, and that's a really big issue when we know that for a lot of carers, waiting for that assessment is quite a distressing situation, and that's you know, that there's often a really long wait time to get assessed. So then once you're receiving that assessment, finding that is not done properly is very distressing. And we also spoke about mechanisms after that. We had Diane from the Seniors' Rights Services in our space, and we spoke about how the Seniors' Rights Services can help with advocating for people who feel that they have received a poor assessment, or where the amount of care that they were doing is being minimised.
Fantastic. Thanks very much, Ada. And finally, Mary's group.
Yes, thanks, Alex. Again, a lot of crossover. I think a lot of what the previous groups have raised is reflected in what we discussed. Some really robust discussion, and thanks to the group for being so open and sharing. We did talk about one-stop shops, information platforms that has a multidisciplinary service approach, which includes information about where to get supports, but also education. The conversations around making things less complex and in recognition of the demands of caring for carers is to be able to have access to navigators or case managers, if you like, to support carers in navigating some of those systems. Proactive navigators as well, to enable them to get access to some supports that might be a little bit much more challenging, such as in the mental health space, being able to get any access to that. We talked about language, both on things like, you know, even if you have access to information system, the language is complex to understand. It can often be very jargonistic and government speak. So really stripping that back to layman's terms to enable people to understand, even people who we talked about, you know, quite people who have a command of the English language still finding it difficult to understand language, government speak, etc., program speak, and things like that. So we talked about, you know, it shouldn't be up to understanding the language of the NDIS to be able to maximise the potential for you to be able to get a good plan in place and get your services you required. So we did talk about really stripping a lot of that back. We also talked about language around carers, the definition of carers, perhaps extending that language around family and friends as well. We talked about recognition of carers. Often, no matter what you've got in place, if carers don't engage as carers, they're not going to have access, they're not going to get access to anything. So we talked about that recognition, and potentially maybe right from the beginning, when there is a diagnosis, a recognition that there is a carer, not just recognising, we talked about not just as carers recognising their role as carers, but also recognition of caring relationships and understanding that from a whole lot, from not just our professionals, but also carers themselves as well, is understanding that relationship. The care recipient or the person receiving care is not isolated. We also spoke about assessments, needs assessments of people needing care. Often they're relied on, they're not great, relied on maybe electronically, people making decisions for people needing care, but having that opportunity to have that that personalised discussion with the care, the person receiving care, and the carer around what that needs assessment might be. So recognising carers at that earliest point of diagnosis. GPs have a role to play in that. So educating GPs around making that understanding or having that understanding or recognition, and the language around that. I've probably spoken about, but there was a lot of things that were crossover. It was a very robust discussion, without a doubt.
That's fantastic to see. Thank you so much, Mary. And thank you for everybody for your sharing. Now we're nearing the end of today's webinar. I would like to mention that the Carer Knowledge Exchange team would like to make sure that we put to use the findings from the session today. The Carers New South Wales policy team will be developing a policy paper with recommendations that came out of the discussion today, which we will be sharing with you, and that paper will inform the responses from Carers New South Wales towards government consultations in the upcoming months. We will also be drawing upon the findings from today to shape the next Carer Knowledge Exchange event for this year, which is the Research Incubator coming up in May 2024. Now, to make sure that you are notified about these next steps and receive the links from today's recording, please make sure that you are signed up to receive the Carer Knowledge Exchange email updates, which is showing up on the slides right now. The sign-up links will also be shared in the chat. Also, please don't forget to check out the Carer Knowledge Exchange digital platform, where you can browse our research library and look at the recordings from previous events. These links are also in the chat. And if you're a carer who would be interested in sharing your experiences in the Care to Share podcast, don't forget to make contact using the details in the chat. Finally, to end today's session, you're about to hear from the Carer Knowledge Exchange's Carer in Residence, Prudence Granger, who will end with a focus on well-being, which is the tradition in these webinars. Before I hand over to Prudence for her final closing guided meditation, I would like to bring this webinar to a formal close and thank everybody for attending and participating today, especially our panelists. We would very much love to hear your feedback on today's webinar so we can continue to improve the events that we deliver through the Carer Knowledge Exchange. In the chat, there will be a survey link coming up. If you could provide us with your comments, that would be very much appreciated. So thank you once again, and I will pass over to you now, Prudence. Thank you.
Thank you, Alex. Just busy popping all those things in the chat before jumping on here. So as Alex mentioned, the intention of this little conclusion is to prioritize well-being. There were a lot of topics discussed that may have caused a little overwhelm or distress. And I think in any given day, whatever it is you're participating in, to take a moment to pause and digest that information is a really, really important thing. So I'll be leading you through a guided meditation, and it'll be quite short as we are over time, but enough time for you to settle with everything you've experienced today. If you are comfortable, I invite you to close down your eyes and then take a moment to acknowledge where and how you are sitting. So for most of you, you'll be sitting on a chair, perhaps. If that's the case, can you please make sure that both of your feet are firmly planted on the ground? And as your feet land firmly on the ground, start to notice the texture that is beneath the soles of your feet. So if you are wearing any kind of shoes or socks, getting curious about that material. If your feet are barefoot, perhaps feeling into the floor beneath, noticing its texture, its temperature. And then taking a moment to subtly press your heels down into the ground, doing this to bring a bit of attention to your legs, noticing the muscles that are stimulated, the strength of your legs beneath you that have been sitting through this experience. And travel your attention from the legs to your body. And if it feels comfortable for you today, I invite you to place one hand on belly, one hand on heart. And start to notice perhaps the subtle rise and fall of belly and chest as you inhale and exhale. If you can't quite feel that sensation, maybe taking the time and to elongate your breath or exaggerate your breath just a little bit so it can be felt. And having the inhalation swell from belly to waist to chest. And as you exhale, feel a softening or release from chest to waist to belly. And your lungs have the capacity to expand into 360 degrees. They are like two large balloons that live inside your chest. And so starting to encourage the muscles of the lungs to fulfill this ability. And they can expand forwards, backwards, sideways, upwards and downwards. What would that feel like if you started to explore all those avenues of expansion? And then when it comes to the exhalation, slowing that down, encouraging it to exit through the nostrils. And completing the exhalation. So sometimes there is a tendency to not quite empty the body of all air. And if it feels comfortable, you might now rest your hands down. And continuing to focus on that process of expanding the inhale completely and finishing the exhale completely. For 3 more breaths. And stepping away from your focus and acknowledging the space you've created. And if you've only created 5% more space between the many, many thoughts you are having, then you have achieved a whole lot. This process isn't about developing complete thoughtlessness or completely stepping away from the burdens or the problem-solving nature of the mind, but to allow yourself a little more space between those processes to feel more at ease, more at calm, and more focused in your day-to-day. And then allow your palms to connect. Start to gently rub your hands together. And again, getting curious about textures and temperatures and perhaps sensations. Maybe you feel a little buzzing, a little heat, a little tingling. And using that to keep you present, to step away from the static of the mind and to step into the experience of the moment. And then once that warmth has really presented to itself to you between the palms, stop the movement and place your hands in front of your eyes, just hovering off of your face. Notice the heat radiating from your palms to your face. As it connects with the face and you feel comfortable, you might start to blink your eyes open. As you blink your eyes open, first consume what you see in front of you. Notice your hands and their unique lines, patterns, stories that they tell. And then as you feel ready, you can start to peel the screen of your hands away to welcome back in the screen in front of you, the room around you. Thank you. If you have any questions, please feel free to pop them in the chat. But otherwise, thank you for your participation today, and we look forward to seeing you at our next event.